all of that work. Under new leadership, we have our first new chief caregiver officer, Dr. Kelly Hancock. So that has to become a sort of fundamental new area of focus in the new world. How do we deepen and enrichen our caring for our own people? That also involves emotional support. Again, we've always had those services, 24/7 available spiritual care, employee assistance programs. But how do we do things now, like simply make sure they have meals when they're walking out of the building? We call that grab and go meals. How do we get creative every single day about showing up for them? A second thing that really needs to change is around thinking in the patient experience world, empathy and safety. These are new things that we don't typically think about that have to be part of how we begin to inquire about the experience of our patients and our caregivers, I would argue, as you well know. That safety, although often considered part of quality and safety and not connected to experience, now it is. When people aren't coming back for the care they need at the volume that we were pre-COVID, it's often because they're afraid that they're going to get COVID. But sometimes it's also related to afraid that you can't bring your loved one with you. I mean, that's a whole new messaging and communication that organizations need to manage about how do we make sure, even if a person can't be there in person, that they're still a part of our care team. Those are two areas that pop out to me pretty easily about things we need to begin to shift and ask about and focus some efforts around.
Very good, and we're going to dive into those a little bit, some more detail with you too, which I greatly appreciate. It has fundamentally changed or highlighted, which maybe it shouldn't have changed, but highlighted the social contract and how we engage with our employees. And it's wonderful to hear what the clinic is doing to address those issues, not just to help people fight the daily battle, but to keep their sanity and reduce anxiety and stay intact through this, which is a big challenge. So thank you. So I'd like to dive down into a couple areas if we could. The first one is the patient trust and experience before COVID-19, kind of level set on what you had built before this hit all of us. Then how that's changed, the patient experience has changed during the pandemic. And finally, reactivation, reemergence. How do we come out of this? When we come out of this, to your point about the new normal, I agree. You could put all of this on a roulette wheel and spin it every day, and that day is the new normal for that day, right? So we'll see how it works out. Yeah. So I want to begin with the patient experience before COVID-19, which sometimes feels like it was decades ago. Before the pandemic in 2018, you gave a wonderful TED Talk on the importance of empathy in healthcare and on the steps you've taken at the Cleveland Clinic to operationalize it. The talk was wonderfully received and still serves as one of the most authoritative statements on the patient experience. Could you give us maybe a short overview of the main points you made during the TED Talk, particularly on how you see the interconnection between empathy and trust? And while you do that, I would ask the audience to imagine how much that informs and helps even COVID-19 if you're doing the right things before, and then, what happened to us since. So, thank you.
Well, that's a big question. So thank you for asking it. I'm going to try to bite at it, and you tell me how I do. So the talk you're referencing is about how do we heal healthcare operationalizing empathy. And it really is based on the premise that historically people think of empathy as this nice optional additive thing that you could do when you're in a conversation with somebody. And often in healthcare, we think about that in the context of a clinician and a patient. But this is also any conversation any of us live in our lives. But this context was particularly around healthcare. And the notion was that we know when we deliver empathy and are effective in our communication around it, that healing occurs, that relationships are stronger. There's influence, reciprocal influence, what we call, right? I'm changing your life, you feel more understood, and I receive a benefit of feeling like I understood you, that I was able to do something for you, connect with you in a meaningful way, that we're wired to want to be able to do that with other human beings. That's just a part of our DNA and literally our neuronal circuitry. And so on all of that premise, could we take that evidence, could we take that and really layer it in at a higher level within our organizations? Can we change our processes and our operations to be more empathic? And if we did, then we would create healthcare systems that feel as though they care about the patients and the people we serve. And that's really the challenge. And could we be bullish about it? So not approach it with soft, fluffy flowers and hope that things change, but what tactically could anybody be doing to make that possible? And I gave some examples of access. I mean, patients wait everywhere. They wait for an appointment, they wait for once they're in the waiting room, they wait when they go down for their test, they wait for the results. They're waiting. It's just this pervasive disease in healthcare. And 30% of HCAHPS comments, for example, about our organization are about the waits. So people aren't talking about your exceptional clinical care. That's not what they share with their friends. They're talking about the experience they have, and boy, the waits are a pain point. And so could we do a better job, not just with access to appointments, but also those delays, doing a better job of proactively managing them? That's a great example, right? Some cities in the US, over 100 days to get a specialty appointment versus 8 days. And on average, somewhere around a month. And that's going up. It's trending in the wrong direction. This is what we knew pre-COVID. We knew billing was a problem. We knew empathy in the visit is still a problem. We know that organizationally, people feel the pain points of the bookends to care, not so much the clinical care that we provide, which is high quality, and people expect that from us. But it's the differentiating pieces. How do we anticipate and know our patients better? So that was really the premise and the call to action. Be bullish about operationalizing it, not just keeping it so personal, but making big process and operations changes. That's the premise. And when you ask me about the pain points in a pre-COVID world, those are them. They're not different than what they are today. But boy, we worked harder to solve them and faster around access to appointment, delays. We've changed the waiting room for sure. We have innovated around registration. We've innovated around billing. And so those pain points aren't changed, but the way we're tackling them has definitely been accelerated.
Very good. So if I hadn't been exposed to what you just talked about, to the kind of synopsis of your TED Talk, and you asked me, Terry, how could I capture empathy in metrics, right, in KPIs? That's a tough thing to answer. But the pathways that lead to a feeling of empathy and the pathways that come from empathic behavior, and you mentioned some of those topics like wait times are measurable. What other KPIs, what metrics have you put in place over time to ensure that you're on the right track?
Yeah, well, I think we're going to talk a little bit about it later, but in the paper I recently wrote in the New England Journal of Medicine Catalyst, I outline what exactly I think we should be asking about in the empathy bucket. And to be quite honest, it's even bolder than waiting times, and it's a little more transparent. So for example, we don't ask about empathy on any survey today. So one of the suggestions is, what if we just said, did you feel cared about as a person? Or another big one, end of life. You told me you wanted to die at home. Did we honor your wish to die at home? I mean, that's empathic listening, and then changing the operations of a hospital to make it happen. And so those are two concrete examples. We've begun asking every single patient on all of our surveys, did you feel cared about as a person? Was the care safe, right? Are two things we're very specifically and intentionally asking about. And the other one is around spiritual care or emotional support services. Were those rallied around you? Were they offered? So that we're caring not just for your physical body, but for the mind, body, spirit. And those are some things I think we could be doing. You asked me earlier about trust. I'm not sure I answered it adequately. So I just want to take a minute with your grace and circle back to it. Trust, very elusive concept. If you research trust in relationship to patient experience, there's not a ton out there. And so many other industries, as you know, use likelihood to recommend as a surrogate for loyalty, originally designed after and published in Harvard Business Review about how they had found 14, I think of 19 businesses, repurchase behavior was associated with your answer to likelihood to recommend that business, right? And that's why it's attractive to many other industries, because it's got that financial tie. When you look at the drivers for likelihood to recommend, so for loyalty, you see teamwork is number one in unadjusted data. Teamwork, number one, empathy, number two, communication, and then ease, I'm going to sprinkle into that mix, even though it's not classically associated. And so those are the things we should be pushing on. For trust, think about it in your own life. I think if who do you trust to take care of your kids, and what's the feeling associated with that? And how do we measure that? I think it's a general call for some better measures of how people walk with their feet and their wallet to continue to use our services as a correlate to trust. So that it's a complicated topic in experience world, and I don't think we're always clear even what we're really after. Are we after a stellar experience? Are we after earning your trust for a lifetime? Are we after, having you pay for us 80 times? I sure hope not, but those are some of the things organizations should be asking themselves in a post-COVID world.
No, but I agree. If you're in this for the long term, right, and you're in this for building patient trust and faith and over a lifetime, then those are the most important things, absolutely. And we do, we measure that likelihood to recommend or to buy again, right? And it doesn't get at the fundamentals of relationship and that trust relationship. So very good. So let's move to our second theme, if we could, how the patient experience has been affected by the pandemic. So forward now from where you were the last 11 and a half years, maybe with the clinic patient experience into February, March timeframe. So during the pandemic, we're engaged in a much more digitized world with home offices, video calls, and the like, and we're seeing an analogy in healthcare where patients are migrating more and more towards telehealth. How do you maintain that human connection in a digital environment? This is a mini experiment right here, right? Do people, after 20 minutes of watching this on the screen, say, yeah, I got to go do something else, right? So tell me, what you're doing there and what your thoughts are.
Yeah, well, everybody has their own experience to share about the digital environment. One of the things that freed it up, I hope I don't need to say, but was relaxation of restrictions around operating in the digital space, right? Around HIPAA. Clinicians moved from being able to use one or two platforms into essentially anything that allowed an audio visual connection. And so you saw that expansion. Perhaps most notably, one of the real successes, I think, is around mental health. Some of the data I've seen that has been shared at the Cleveland Clinic is, there's been surveys of people asking about their stress level, right? And most of us are about an 8 or 9. These are people who are working and have kids, that they're at an 8 or 9 out of 10 being the worst in terms of a stress level. We see that stress play out as well for caregivers in organizations, that stress levels are pretty high, even though they're maintaining performance and feel safe and cared for. And as well, really important to think about, we've also been tracking things like certainly serious safety events, but also workplace violence, right, which is 4 times the rate of violence in healthcare than in other professions. And we've seen some of that play out, I think, because the stress level is so high that it's almost like people can't have one more thing, right? It breaks people's back. That's important to comment on because virtual health really opened the door for mental health services. And I think that has exploded. That part of empathy operationalized is meeting people where they are, both physically as well as mentally and emotionally. And this way we've been able to, right, reduce the stress of having to drive downtown, reduce the time you spend waiting in a waiting room, reduce the amount of, copay dollars you spend. And all of that has a cost to it. All of that has a mental cost as well as a financial cost that we can capture. And so being able to meet people where they are on video in and of itself is a beautiful example of operationalized empathy. Connection in the visit, though, doesn't just happen. If you talk to most clinicians, they think they're amazing clinicians with top-notch communication skills, as I also talk about in the TED Talk. And right, that's just not the case in all of the patients' eyes. So I think we need to be very deliberate. We rolled out training about how do you enhance relationship across a virtual platform? What does that sound like? What should it look like? And I can tell you as a MS practitioner, virtual creates this beautiful opportunity to engage in brand new ways that are rewarding to me. So for example, patients I've been taking care of for 10 years, I get to see them on video and then say, hey, I'm noticing that behind you, you have, a huge array of cooking pans. Are you a good cook? Or last time I saw a liquor bottle, which probably was good to talk about nonetheless. And other times it's their family. And so it enables a whole new window into the lives of the people that I'm trying to connect with all the time. It's been beautiful, but it has to be intentional. So I'm making that time to build that rapport. And when we do that, we've been measuring, we deployed virtual surveys around patient experience in the digital and virtual environment. Exceptional ratings, so nearly 90% on all ratings of likelihood to recommend, ease of the technology, feeling the empathy of their caregiver. And so again, we have to make those investments if we want that experience to feel relational. The tech should support the relationship, not the other way around. No, those are some of the things we've done. I would just comment, and that's true of spiritual care services. That's true of clinical services. That's true of grief counseling. We've offered virtual funerals. We've offered virtual baptisms. We've really gone into spaces that we've never been in before, and maybe we should have been, to create connection.
Agreed, because it's this, we've kind of been in healthcare, maybe especially in kind of a one-size-fits-all, this is how an appointment works, right? Like you said, you get in your car, you drive down one of us. Now we're creating ways, because of this crisis, to deal with patients in maybe ways that work for them specifically, right? The generation that I come from, which is, I can say older because I'm talking about myself, that is used to, was used to high touch, is different than maybe the younger generation. I've got the daughter of a CEO of a large health institution who's a good friend. He said, how did you choose your doctor at school? And her response was, I picked out the one that was the least interactive with me from a human standpoint and had the best online features and functions so I can get in and get out, right? So it's wonderful that you're helping to adapt and adopt.
I do think part of the opportunity, I know you probably don't want me talking about this before we get there, but we've done the studies around what our fabulous marketing team did a bunch of studies around what different segments of the population want, for example, around primary care. And you're right, not all of them have the same needs around access. And we need to actually pay attention to that, right? So if I know you're a convenience seeker, or you might fit into that segment, rather than a super savvy, 20-year-old who doesn't have any health problems, we should pivot our strategy of engagement and marketing and virtual offerings to meet you where you are. And we're just on the cusp of getting to that level of insight and personalization, but boy, we have to go there right now.
Very, very true. So it does bring up, and you brought this into the discussion that, and I've talked about this before in one of your interviews, that patients and caregivers are one and not separated, although they're just by different needs, right, at times. And I think that's maybe more acutely brought to bear most recently with COVID-19. How have these interactions between patients and caregivers change beyond just the just the telehealth side of it, right?
Well, we always separate those conversations, and that's always bothered me, just personally, that we say, first of all, we call them patients and put them sort of in this bucket over here. We'll give them a satisfaction survey and see what they say, or we'll train clinicians this way in communication. But then we'll sort of throw some of that training out when we go to talk to each other. Right? And we have such an enormous opportunity to say, instead of just patient-centered care, which was originally defined around respecting the values, needs, and preferences of our patients, really values, into person-centered care. I mean, we say that, but we still keep them in these distinct buckets. And suffering knows no bucket. Empathy knows no bucket. And I think a smarter strategy for organizations is to begin to think about, how do I more deeply understand the needs of both? And then how do I deliver to those needs? And then how do I measure my delivery, of course? And I'm making the case that the measurement shouldn't be different, that we should essentially be making promises that I really want to keep around we will partner with you. We will keep you safe. We will care for you as a person. We will make it easier. These are the same promises that then translate to metrics that we could be asking of both. And that will move us closer to humanity and out of what survey we're using. And the caregiver survey is different than the patient survey, and much closer to actual person or human-centered care, which is a dream of mine.
I've been in healthcare for 40 years, and it's been much more over that time process-oriented with patients as items to be fixed on an assembly line, right? So this is a wonderful evolution, and thank you for leading that. So let's move on to reactivation now. What happens next?
Oh, is that all the question is? So what happens next as we think about COVID in a post-world, we keep losing my partner here, is thinking toward the future. I absolutely think the measurement needs to change, as I've just walked through. Organizations need to continue the efforts that we've had around caring for our caregivers differently. And I think that the learning how to connect humanity in a virtual environment is going to be a big piece of that. Something else I was thinking about earlier when he asked me about operationalizing empathy, particularly as we think about safety and other issues, is the idea that we need to take all these disparate sources of information and feedback we have from patients and possibly our own caregivers and get it to create a better story. So for example, right now, if we think about patient experience data, we have age gaps, we have multiple other patient satisfaction surveys, we have complaints that come in, we have letters patients write, we have safety events, we have disclosures, we have all these disparate sources of data, and being able to pull them together to create not just a cohesive story about their journey across the enterprise, but also what that individual patient needs. Meaning, if you look at most healthcare systems today, I don't know that you got the wrong taco for the last 18 times that you were in the hospital. Boy, that would be helpful to lead with, the next time I'm going in to round on you. And we haven't pieced that together. That is one of the opportunities as we move forward, is deeper insights that can then be leveraged to change the conversation. We're learning from other industries in that space who do it well, and I think that's an opportunity for us in a new world for sure. Welcome back.
Thank you. I will tell you, I'm getting faster at getting back in. So
doing good.
I don't know when I'm frozen if you're still hearing me or not, so I apologize. Thank you for jumping in again. Yeah, the new COVID-19 environment is going to be with us for the foreseeable future, unfortunately. People ask me all the time, how long? And I say, I don't know. Is it a year from a vaccine being out there? Is it farther than that? Who knows? So you're doing a lot to help people feel safer coming back, and to also provide possibly alternate avenues for them, like telehealth, maybe outpatient clinics. How do we do more to help everybody feel safe to come back?
Yeah, well, we tried to create, so number one, we studied the problem. We interviewed patients we have a group of patients who work with us on a variety of projects across the healthcare system. We call those patient partners, healthcare partners. We also used traditional market research to understand what are the fears. Before we assume we know, we actually went and asked and studied. That's just a cornerstone to design thinking that'll teach you something time and time again. And so we listened. And when you listen, that is fear of getting infected, and it's fear about not being able to bring your loved one for comfort. Were some of the two big things that bubbled up. You're seeing people not use emergency rooms or getting routine care as much as they can. So ways we've reactivated around that or responded to those fears. Number one, we put out a video that walked people through the entire experience from parking to the clinical visit to sort of say, this is what it's going to look like. This is what will feel differently. This is what we want you looking for as we clean for safety or talk about safety in an effort to keep you safe. So messaging around that repeatedly. Visitation policy changes, of course, making sure we're communicating that, not just the decisional framework for how we make those decisions, but we do empathy training for our screeners at all of our sites. Again, setting them up for success in the conversation that's really difficult around how do you say, I appreciate you want to come in, you can't. How do we do that with empathy for people that may not traditionally be used to being patient-facing? Another thing that we're doing to reactivate, as many others are I don't want to say touchless registration because it's not touchless. It should feel high touch, but that laborious, you call the register and then you come in and then we're going to recheck all your credit cards and collect all your information again, moving all of that virtual. So you can upload that information, you can do consents from home, you can register from home, and then even pay your copay from home, get authorization. All of these things should happen before you come to the visit. And cost estimation is a big piece of that, right? Being able to deliver we didn't go there too much today, but I'll tell you, there's no reason we can't deliver on cost transparency for patients in the new world. And so let's do it. And let's do it now. So that registration easing that process and making it virtual as much as possible. Those are some of the things I think that have happened to really get people back in. And proactive outreach, right? For people who we know are avoiding their colonoscopies and their mammograms, what we don't want to have happen is people get sicker because they're not getting the preventative stuff. And so very sort of intentionally reaching out to those patients, anybody who got canceled, rescheduling them to get them back in, and really, really thinking through that design process of how we're going to do that.
Very good. So I'm going to ask you to maybe in this next segment, this next question, to combine your thoughts from your recently published journal article and this emergence topic on what is the way forward. How do we get there? How do we stay there? I think, the fear that to address these issues as they're emergent, how do I create stickiness around that, and how do I find this path forward and not go backwards?
I'm sure I have all the answers there as to how not to go backwards. I mean, the first really is to do everything you can to make patients feel safe. I think that has to remain a patient experience priority and messaging for places that want to bring patients back in. They need to know that they can trust us, right? I mean, and if keeping me safe is not a part of that trust conversation, I think we've missed the boat. So tell me how you're keeping me safe. Put that front and center in the communication so that they feel comfortable coming back, especially now that we know that's one of their fears. Another one is caring for caregivers. I don't want to be saying that in 2020, but this deepened our ability and our execution on caring for the people who are showing up and trying to give their best every single day. At Disney, you'll probably tell me, from some of that thinking around, if we just cared for our caregivers, they would deliver exceptional care. I might take a little bit of argument with that sometimes that's true, and sometimes we haven't seen that to be true. So we need to keep doing both, right? We need to set our caregivers up for success, and we need to make sure that they're able to give their best every day. And when their buckets are empty, we do what we can to fill it. And I like what you said about that social contract. I think that's important for people to give attention to. The third thing would be designing a virtual experience for both. There are going to be caregivers that continue to work in this way. And we haven't we kind of stood it up and said, here you go, now your whole team's on the screen. But that doesn't necessarily foster connection. And same with the patients. Just because you get them set up on the virtual doesn't mean we don't have to do any of that hard work to really ongoing understand their experience with it. Almost like the plan, do, cycle of continuous improvement or design thinking. Check, we have to keep going back and improve. And again, the pain points around that, making sure we're intentional about connecting in that interface. And you have to train people, and then you have to give people the time to get the training. You can't say be more empathic to people who don't know how. Sometimes people don't have the words. They don't know the right words. And so we have to work with people to make sure we get it right. We've done communication skills training around that. It can be done, and we have to give people the time to do it. Number 4, we haven't talked about disparities that COVID has exacerbated and highlighted, I think, in a brand new way. Racism, we declared a public health crisis in the city of Cleveland. There are discrepancies in quality, safety, and experience of Black Americans, and we need to pay more attention to that moving forward. So number 1, acknowledge that happens, look at your own data, and then come up with mitigation plans around that. We want to hear all voices. And then lastly, ease. This is a concept that's threaded through pre, during, and post. We have to make the experience easier for patients nearly at every touch point and learn from when it wasn't easy last time. How can we do a better job of engaging that patient the next time? We developed, a quick example, we developed digital care plans with our IT teams and our medicine teams for COVID care. And although it's pretty easy to register and log in through your EHR, about 30% of patients take us up on that offer. And then we worked to infuse, not just making the technology easy, but asking about their mental health, their stress points. Did they have advanced care planning that they wanted to do? Because people were scared that I have COVID now, I might die. Our own caregivers were scared. What happens to my family if I get this from my patients? And so being willing to have that conversation in the digital tools, we have to infuse it to make it easy to talk about, not just easy technologically to do. Those would be my big 5 as we think forward.
Very well said. Thank you. And I was going to ask you about the differences between the care that we provide in the U.S. health system versus globally. We do have attendees on the internet today that come from around the world. Listening to you speak, these are universal maxims. That empathy should be universal. So, but any advice to those not in the U.S. health system?
Yeah, well, I hope I get an opportunity to hear from all of you on the phone. Cleveland Clinic is a global operation, so through that lens, I can share we've mapped some of the journeys of patients in London, in Abu Dhabi, in Florida, in Toronto. So we have some experience in understanding what does that look like across the globe. And you're right, these are universal truths. Suffering doesn't know where it is, neither does empathy, but it can sound differently. And sometimes the expectations of patients are very different. And so we need to be humble enough to listen and learn from our own culture and our own environment. A good example, in Abu Dhabi, there's different perceptions of wait. Oftentimes there's an expectation that you're not waiting. And I mean, here, just like we said, we're like, no, your appointment's at 9, and expect people to follow that. And that's not necessarily how it works. Or there's an expectation in different cultures that they'll have somebody with them at all times and that's acceptable. And again, we have to, I think the premises that are universal are not necessarily the how we do that or how we operationalize that, but how we listen and how we learn and apply empathy and creativity. Those are universal for sure. But eager to hear from those on the phone.
Very good. So I've got some questions. Thank you very much for your insights. And let's see, I'm pulling them up off my phone. So first one, how do you balance patients saying there are too many screenings and too much distancing with those who say it's not enough, right? That people who are conscientious objectors to mask wearing and that kind of thing.
Yeah.
Difficult.
Yeah. Well, of course, there's no easy answer to that. We hear both. I mean, I hear caregivers who are very afraid that even with masking and universal precautions and PPE that they have, that there's fear. And on the other side, people who are saying this is all nothing, it's overblown. And again, the opportunity for us is to listen to both sides, to call out the disconnect. It's really interesting you're saying that, because I'm hearing some people don't even believe this exists. And then I'm hearing your perspective that, you want more. And to highlight to people what we're trying to do is seek some common ground. And that common ground is safety for everybody. No doubt about it, right? The common ground is our mission is to keep everyone as safe as possible. And it's very interesting because when you're in a public health crisis, ethically, as my ethics colleagues will tell you, it's supportable to not deliver to an individual preference, but instead to consider public health, right? That is a decision shift that occurs in a pandemic that I don't think people are ready for. But that's what's required, is the care and safety of everyone, not just you. And so that has been the common language and the common ground we seek in those conversations.
Very good. Then how can we influence the healthcare industry, to move away from patient SAT scores as the end goal and instead focus on data to design better care and experiences? So how do you make that leap? Maybe in your institution, maybe better focus. Yeah.
I don't know if that's true. I mean, although that's my perspective, that we need to change and evolve, we need to think relationally and longitudinally across all settings. In the paper I wrote, I sort of propose how it all needs to change. And the methodology needs to change. We need to move from paper surveys to e-surveys. It needs to move from 6 weeks late to real time. It needs to include virtual. So there are a number of very tactics that need to be taken, I think, to pivot. But what you're asking about, I get the sense, is more around that cultural jump. There's plenty of data. What I have tried to do is position it as a differentiator. Look, everybody's asking about HCAHPS because it's required. Everybody, right? There's no differentiator when it comes to the experience of HCAHPS. And if your HCAHPS return rate nationally, right, I think I quote, it's 26% versus 22% in our own experience. If you're basing your entire experience strategy on a survey in one setting that has a 22% survey return rate, response rate, that's problematic. You want to differentiate across all channels for all of your patients in every setting at every time they touch you. And that survey strategy doesn't work. So that would be what I would try.
Very good. Here's a poignant question to one of the topics you brought up earlier. How does the clinic address care inequality across patients?
Well, as I said, I think COVID has exacerbated for everybody that we need to learn more. There's so many layers to that. Even as an individual, right, we all have to commit to humility and learning more about what our role is, both as a person and a leader. What is the data that can inform our solutions? I think everybody wants to fix it and make it right. The question is how and where are we going to give, when people have limited bandwidth, how do we make sure their energy is pointing in the right direction for solutions? For us, we're tackling that at a global scale at many different levels. I would say we're certainly looking at our own data to understand where those disparities are deepest. And how to engage with our community, not just, right, that healthcare has the solution. There are many communities that have been working on this for a long time. We need to continue to bring those different groups to the table to make sure their voice is heard, perhaps more intentionally than we have in the past. We double down on our value as an organization of inclusion. That's not just inclusion of races, sex, gender, or culture, that's also perspectives. As I said, at a community level, we declared racism a public health crisis here, which means we've collaborated with the city to drive efforts around it. And lastly, I would say one of the issues that has emerged for us, to give you a discrete example, is to teach people how to speak up about it. So we care for all sorts of patients, and oftentimes there are racist or inappropriate comments to our caregivers. And one of the things I think we need to do a really good job of is making sure that our caregivers speak up every time they hear it. And as we've learned with empathy, sometimes people need language. What would it sound like to say what you just said is not okay? And that's hard when people feel emotionally charged about what they're hearing. So standardizing how to do that, we use the Quality and Safety Mnemonic, which is CUS, not an attractive name, but says, I'm concerned about the language you're using, right? I'm uncomfortable, and it escalates. So as I use the word concern, uncomfortable, I don't feel safe, that's escalating language to tell somebody it's not okay what they're doing or how they're behaving or speaking. And so we've run all of our teams through that training in the last month to make sure people can actually do it. Because it comes up more than I would like to say. So those are some things that we're doing that I'm aware of, and certainly more efforts that I'm not aware of, but those are some of the insights I would offer.
Okay. So combine two questions into one. How are you measuring patient experience in the virtual world? And then moving from that to how are you retaining patients in the virtual world and kind of knowing that you have, right, monitoring that?
So I want to make sure I caught your first part, which was how are we measuring experience in the virtual world? Yeah. So we have one of my missions was to get the same 5 questions on every single survey we offer. So although we might have an inpatient survey or outpatient survey, we've added the same 5 questions: likelihood to recommend, teamwork, empathy, safety, as well as ease to every single survey that we do. So we have a virtual survey that offers some national comparisons, but we've added those 5 questions to it. So we're making sure that the technology is easy, people are feeling that there's a genuine connection, as those feel like the most important things to us as an organization. And then I think that's that continuous improvement loop of going back and making sure. What we've learned in that through the virtual experience is sometimes the process to get people who may not be as digitally savvy as others up into the platforms needs some process work. So we're working through that. That's been one of the lessons. How do you keep loyalty? Look, there's not a scheme to loyalty. When people feel cared about, they'll come back to your organization. And that doesn't just mean emotionally cared about, but when they're not encountering fragmentation and friction across your system. So that combination of ease and empathy, I think, is where people should be spending their time.
Okay. So the next question has to do with how you gain executive buy-in to the whole program. Now, I know the answer to this question as it relates to the clinic. You've been on this journey for so long and so successfully that people want to come to the clinic and do this kind of work and work in this environment. And if they don't come, don't have them come, right? But how does somebody who's not done this for a decade get executives to pay attention besides having them watch your TED Talk and reading your journal articles, right? So how do I get my executives to engage?
Yeah. One thing I've learned about myself as a leader over time is that one of my gaps or opportunities is that I sometimes think people think just like me. Just like the prior question around, do we double down on HCAP surveys versus do we do everything else, or how do I get people convinced we should be doing everything else? So I make the assumption mistakenly that people think like me. So first of all, I would encourage you not to make the same assumption. If you care about experience, if you care about patient experience in healthcare in particular, that one of the first things we should go do is listen to other executives, particularly naysayers, to understand, I would say naysayers, not just naysayers for the sake of naysayers, but naysayers who have influence. I call them nodes of influence, right? You have to understand the forces that are working with you and working against you so that you can better craft your story. And that will create, that's your absolute first step, no brainer. And you'll probably walk away being like, wow, we have a lot of people who care about experience, but might frame it, might think that needs to move in a very different direction than I do. And then that's the bridge to make. Not that it's important, because most nearly every single caregiver, every single leader I talk to thinks it's pretty important. But the difference in the nooks and crannies of it are, how do we get there? Where do you think we should be spending our energy? People have many different ideas around that. And so deep listening is probably a first step. And then the story, I think, comes easier. And if that feels intuitively obvious, the second thing I would prompt you to do is take lessons from other industries, right? You need to look at industries that have leveraged design thinking, which contains empathy as a key component. Look at industries that are customer obsessed, like Amazon, like LL Bean, like the one, right? These are organizations that have deep foundations in deeply understanding the customer and not meeting expectations, exceeding expectations, and study them a bit so that can be a part of your story as well.
Excellent. Thank you very much. So we're out of time. I apologize for those who submitted questions that we didn't get to them. Dr. Boyce, thank you for your time. Thank you for your insights. It's been delightful for me. I can't hear about what you're doing enough at the clinic and how this is so applicable for all of us. So thank you for that. Thank you for your efforts. And again, for being on the front line and for serving those on the front line. With that, I'd also ask everybody to, in follow-up, to go to the Siemens Healthineers website and for more information on the patient experience and more information about Siemens and the Cleveland Clinic. So with that, we'll wrap up. Dr. Boyce, any final thoughts for us?
Two thoughts for anybody on. Please feel free to reach out. If we didn't get to your questions, I'm happy to try to help answer them. The second piece is just to reiterate a call around there is such a thing. This has been an overwhelming, unprecedented time. We have all gotten through it. The goal isn't to get through it. There is this beautiful concept called post-traumatic growth. We need to thrive in this new world. And some of what we're talking about today will help get us there. It's not a cure, but it will help get us there. And I wish that for all of you on the call. Thank you for all that you're doing. And thank you so much for having me.
Wonderfully said. Thank you again. And thank you, audience, for joining us. Wishing you all peace, health, and be safe. Thank you.
Thank you. Take care.